Great. Okay, brilliant. Thank you very much. And it's a pleasure to be here. And I really actually, it's very interesting to hear Clara's context. I have to say, I'm not an academic, and I don't come from the information science world. So it's been very interesting just even prepping myself for today's event. So thanks again for the invitation. And I suppose I'd like to just start by explaining a little bit about NALA. We're the National Literacy Agency. We're rather unusual these days insofar as we're a charity that is largely state funded, and we're concerned with the whole area of adult literacy in the broadest sense. So one of the areas that we work in is health literacy, which is what I'm going to talk to you about today. But largely we're concerned with, I suppose, people's experiences of literacy and numeracy, and indeed how it can be a barrier to their fulfillment of their lives, and not only how it has come about, but why it seems to be perpetuated in all modern societies. So just to say, what I'm going to cover in the presentation is what is health literacy and numeracy and why they're important. What does a health literacy friendly approach look like? That's a term we just use in NALA to describe some of the work we do. And I'll finish up with just some small examples of how we can communicate more effectively using some simple ideas and tips. I suppose literacy very generally, there are dozens of definitions, but the definition that we work from in NALA uses that umbrella term that literacy covers reading, writing, numeracy, language, technology. But it comes from a philosophy, I suppose, of stating that a beginner reader isn't a beginner thinker. And also, we also embrace the idea of literacy as a social practice, which really means that there are all different types of literacies in our world, and they all need to be, I suppose, embraced and recognized. Obviously, there are dominant literacies in our world, and they sometimes become the ones that are taught in schools, or indeed the ones that are most recognized. But the way we work, I suppose, is to understand that literacy is a social practice, and therefore we acknowledge and respect all the literacies that people will have in their lives, but also helping them, I suppose, to build on those literacies so that they're strong for their future. The idea then of what is health literacy and numeracy, I suppose we've divided this into two parts. Essentially, it is ensuring that health information is understood so that people can make informed decisions. But it's often in academic terms understood really as the individual's ability to understand and make those informed decisions. I suppose in NALA we've decided to also put an emphasis on the provider of the information as having a responsibility in relation to how they communicate that information, and how they take into account the wider needs of the people that they're communicating with, so that ultimately good health literacy and numeracy would look like that mutual understanding idea that we see at the bottom of the slide. I suppose in breaking it down, health numeracy, as you'll see in the slide there, is the ability to understand and use quantitative health information. So as you can imagine, in a lot of health and medical information, there's quite a strong emphasis on quantitative data. So basic calculations, a lot of text using graphs and so on and so forth. So often health numeracy is sort of hidden behind the health literacy term, if you like, and we don't recognize how much actual numeracy is in the information that people are being asked to digest. So often in health information, it can actually be one of the biggest barriers. The Cancer Research UK recently found that 46% of people got the answer wrong when asked whether a risk of 1 in 100, 1 in 10, or 1 in 1,000 resulted in more chance of their getting a disease. And they also found that those with poor numeracy skills were less likely to take a bowel screening test. All of the research really on health literacy and numeracy shows how it impacts people's health outcomes negatively, in short. It's The OECD, I suppose, are probably the largest data producer in the area of adult literacy and numeracy, and their work in this field dates back to the 90s. I've just taken out some of the results for Ireland. So the OECD survey covered initially, I think, 24 countries, but I think there's 40 countries now that are covered in that survey. But the data for Ireland, and the reason I've blotted it out there is just to give you a few minutes to jot down what you think might be the answers. You know, how many people in Ireland do you think have difficulty reading basic information like a timetable? Or indeed, how many people in Ireland do you think have difficulty with basic numeracy, for example? So if you have a little think there, what you think might be the answer, and I will move on to show you the results. So Ireland at the time of the first survey results was 17th actually in literacy and 18th out of 24 countries. So certainly below our, I think, our educational statistics norm. So we'd usually be very high performing in literacy and numeracy for children. However, the adult population hasn't performed as well in comparative surveys. So quite a large percentage of the population in Ireland experiencing difficulties with understanding basic information and indeed basic numeracy activities. So when that survey was carried out. One of the tests that was used, because often people find these examples, I suppose, shocking that there would be that many people who may have a literacy or a numeracy difficulty. But one of the tests that was used looked like this, and effectively people were asked to locate how much sugar is in the pot of yogurt. And so for those of you who could have a look, you'll be able to see sugars is down there and you'll see the 1 gram. So that is a relatively, you would think, basic test. And that would be the sort of test that people would be asked to perform in the level 1 category. You have to get enough of them correct in order to move on to level 2. So that is effectively what a basic literacy exercise looks like that PRAC would have used to find out what level people were at. In addition to the OECD's work, there has been some specific studies around health literacy, and one particular European health literacy survey was carried out just in 8 countries. I know in the Irish context, we were involved in actually even accessing funding for the academic body that carried out the research. But you'll see from the results there that really, in terms of the general population's health literacy levels in those countries, there was a sizable minority of people who wouldn't have had sufficient or excellent health literacy. So in the Irish case, it was around 40%. Better performing countries like the Netherlands, you can see there, and then obviously countries that did worse, for example, Greece. So why is this important ultimately? And I suppose what we've been trying to draw out, I suppose, is the implications of people having poor literacy or numeracy to perform in the modern world. And in a health context, you can see there's been quite a lot of research to see how it actually impacts their health. So drawing together that research there, you'll see people are less likely to use screening, they're more likely to be hospitalized, they have poorer understanding of their treatment, therefore they're less likely to adhere to the medical regime. They report poorer health overall. Actually, that was one of the questions most recently in the PRAC study that I mentioned earlier. And people are presenting in later stages of disease with the attendant consequences of that. So it's important because certainly in the Irish research, we know that about 1 in 5 Irish people stated that they weren't fully confident that they understood the information that they were receiving from a healthcare professional. They also stated that they would only ask their healthcare professional to clarify information if they did not understand something they had said. So less than half of those people said they would do that. 66% of people have difficulty understanding signs and directions in Irish hospitals, and 17% of people have taken the wrong dose of medication at least once. So these are small-scale pieces of research that have been carried out in Ireland to follow up in terms of has actually been the consequences of people not necessarily fully understanding their health information. So recent research found, again, a few little question marks there. So if people want to have a minute or two just to have a look at those statements. Again, they are in an Irish context. But what are the likely numbers of people, for example, who couldn't define the term prognosis? People aged what were least likely to ask a doctor to explain something, and what percentage of Irish people were calling for less medical jargon. So just to reveal some of the answers there. So quite a high percentage, you'll see there, 39% of Irish people were calling for less medical jargon. So I think that was really interesting from our point of view, that people understood that there were actually words and terms that were being used possibly commonly in their medical experiences, but people didn't really understand them and would prefer if they were explained. Younger people, surprisingly, were least likely to ask for further information. Embarrassment was ranked as the main reason for not seeking information. And 45% of the people we asked in this particular survey couldn't define the term prognosis. So essentially, as an advocacy body in NALA, what we've tried to do is bring that research evidence that is scattered throughout the academic world, through various different academic areas, in fact, to bear on policy in Ireland. So because we are a lobbying body, we were certainly in the first instance lobbying for government to have health literacy as a policy. And this was recently achieved, one might say, in terms of our current population health strategy, which is called Healthy Ireland. And you'll see there, it put in that kind of commitment to address and prioritise health literacy in developing future policy, education and information interventions. So it was the first time in Ireland that there was a specific reference in policy to health literacy. And in terms of then implementation of that policy, our health service executive, which would be our main health body, took on the provision of health literacy through its work. Very much at an early stage, I suppose, in trying to understand what does that look like, what would those interventions be, and certainly some of the easier ways to address it have come through very sort of, I suppose, specific communications, for example. So we've probably more examples of communication work that has happened to improve health literacy than perhaps educational work at this stage. So what does delivering a health literacy friendly service look like? So not content with bringing the research to bear, getting government to adopt a health literacy policy, NALA then set about trying to identify what practical examples could we devise working with health practitioners that would actually boost or develop health literacy. So we coined this idea of health literacy friendly approach, and that was effectively trying to, I suppose, proof operations within health services, whether that was in terms of their policies, procedures and practices, to make sure that they were building in this literacy numeracy dimension into their work. So we produced a literacy audit tool, essentially, first a paper-based one, and now it is done electronically. And if you like, it's a way for healthcare practitioners themselves to audit their own policies and practice, ask questions, check evidence, whether they're there or not. If there's no evidence, for example, maybe to go and find some, if they actually don't do something, to put in place a practice and then monitor whether or not it actually has made a change. And in some cases, we found many healthcare professionals and practices were actually quite supportive of people who had literacy and numeracy difficulties. However, there were significant gaps in certain areas, and the audit tool then was very useful in terms of unearthing those, if you like, and in a manageable way helping healthcare providers to do something about it. We also devised quality standards. So again, very simple set of quality standards that would help either whether it was a chemist, for example, or a hospital, for example. So anything like that where they could actually bring in these standards and say, do they have a policy? If they didn't, maybe start there with putting a policy together and getting some information how they might support their staff, for example, then deciding that they've actually put in place a number of measures. So for example, they use plain English and they can evidence that in terms of their written information. Checking of understanding became quite an important one, because often people would feel that they had been very clear or they had provided all of the information to the individual. However, they didn't check that the individual understood that information. So that was a really interesting shifting of the dynamic, that it isn't a simple case of making sure you give all the information. You also have to check that people understand it, and building in little techniques for how to do that. One of the practical then examples of this work was this crystal clear mark. So we worked with pharmacies, the Irish Pharmacy Union, and a pharmaceutical company, Merck Sharp Dome, to identify, following up the use of the audit tool, a practice whereby pharmacies could report that they had met the standards, if you like. So in a self-check kind of a mechanism, and that we would then do some small review with them and help them bridge any gaps that they might have. And if they achieved the objective of going through the crystal clear process, they got the mark, and the mark would be something that they would put up in their pharmacies or chemists, so that they would be able to demonstrate to the public that they were making efforts to make sure that they were communicating clearly and meeting the standards that I'd refer to there. We tried a similar approach actually with general practitioners, doctors, family doctors, and found it much more difficult actually to get them to voluntarily try it out. But they did accept health literacy training specifically for GPs in Ireland. So there's definitely, I think, an interest in this from different types of healthcare providers and practitioners. But not everybody can adopt everything, if you like, depending on their setting and their profession. So in terms of just communicating more clearly, some of the simple examples that we would show to people, for example, is we would take common health information or common health terms, and we would just be able to demonstrate how you could actually present those terms in a more simple way. And essentially, I think helping people to explore their language, watch their language, think about the terms that they're using. It's not as if they don't actually know the easier version. They just are very used to using the professional language that they are comfortable with, and have perhaps often maybe lost sight that this isn't language that is in common use outside of their professional realm. Or indeed, for some people, it is just genuinely very challenging if they don't have strong literacy or numeracy skills. In practice, then we would, give examples like this of showing what information looks like when you do use all capitals, when you do use tight line spacing, when you use italics, put everything into a center font, indeed actually sometimes have very small fonts, and just show again an example of what should be done instead. So often people would think that the fancier they can actually make the communication look, the better it will be, whereas its actual readability could be very challenging. So showing people how to use these very, very simple tips, nothing that everybody can do, but the difference that it makes to the reader and to their understanding of the information, because essentially we all want to be able to read and understand information that we have in a very information-rich society as quickly as possible, and ideally the first time we read it we would like to understand it and be able to act on it. General tips then for using plain English would be sort of another area that we would focus in on. So again, bringing very practical examples to, in this case, healthcare providers, to see what they could do. And signposts are really interesting when we've worked with a couple of hospitals, for example. The reality is consultants know their professional area. So if you're going to the hematology department, the consultant knows that the hematology department is the hematology department. If you want to get people just to get their bloods, for example, it might be just easier to use the more common words like blood. So that was very interesting for hospitals to see that they had actually used all the language that would be specific to their professions, as opposed to the language of the people using the hospital on an occasional basis, which would be the patients or the customers. Plain numbers was another area. There's a huge amount, as I said, of numeracy in a lot of health information, and yet it's kind of taken for granted that these are commonly understood concepts. And we've done some work looking at labeling, for example, and suggestions, because it's a heavily regulated area, but certainly there's quite a strong emphasis where labeling is, there's parts of it are actually regulated and parts of it are not. So there is room for improvement that individual providers of information can make themselves outside of the regulatory system that they might work in. But you'll see there, for example, you know, show, don't tell, for example, point to and mark 2.5 ml on a syringe, as opposed to assuming that somebody would know what that is. Present numbers in context. For example, a baby at 15 weeks is 4 inches long and weighs in about 21, 22 ounces, about the size of an apple. Use tables over graphs or charts and leave a full space between a digit and a symbol. If the symbol is a letter, for example, 25 and 400G. So lots of examples, and for health providers or practitioners who are actually presenting or using this kind of information all the time, it just gives them ways and means by which they can at least check their practice, see if there's something they can do, and then test out whether or not it actually has had a beneficial impact in terms of their own customers or their own clients or patients. Food labels, as I mentioned, are kind of a really big area, primarily because there's so much information in them, and it usually is presented in very small print, and there is no uniformity. And there's a lot of work happening at a European level to bring in some kind of uniformity around it. Again, there is some regulation also there, but where anybody who's producing information can make a difference, these would be the kinds of do's and don'ts that we would point out to them that they could actually utilize, and that they would make a difference in terms of how well people will be able to read and understand the information. Just before I go into the questions, I suppose I'll just go back to this one again. It's quite a contentious area because there is a sense of whether or not people actually want individuals to understand the information, because there is a huge commercialization, I suppose, there in terms of food in particular, about how healthy food is and how food is marketed as such. So it's quite a contested area, but there is a very strong lobby group growing within the European countries to see how it can be done better. So yeah, I suppose in short, it's the work that we've been trying to do, I suppose, has tried to pull out from academia in particular some of the very interesting things that have, I suppose, developed the concept of health literacy, tried to understand what that means in reality, try to understand how it can be implemented in terms of policy and practice, and then how to support healthcare providers and practitioners, whether they're settings like hospitals, right the way down to something as local as a chemist or a pharmacist, to do something, you know, to make, we use that term, make one small change. So, and also I suppose that bit about seeing themselves as part of the solution, as opposed to the focus sometimes in research in particular, is that the subject, if you like, is the person who has low literacy, therefore essentially they may have the problem, as opposed to, I suppose, understanding that the provider of the information can bring quite a lot to the solution. I suppose in NALA's wider work, we obviously encourage people to come back into education themselves. So we feel that we're already promoting that side of it, but our work with healthcare or within that health world is very much around seeing how providers and practitioners themselves can make a contribution. And ultimately it serves them because they are trying to serve their own patients and customers as best they can. Just to flick on there, there's some videos. Ask Me 3 is just the one I just wanted to highlight there. They were like, it's a very simple tip so that effectively the health practitioner asks the patient, if you like, to ask the 3 questions about what they've now understood to be their new condition, for example. So they're not saying, you know, did you understand me? Because most practitioners will say, or most patients will say, yes, I did. Whereas they're saying, you know, teach me, tell me what you understand that you've got from what I said. So they put the onus back on themselves, which can be very, very useful. And then finally, lots and lots of resources around health education, health literacy education. So certainly our own health service executive, they have their own guidelines for communicating clearly, right the way through to the literacy audit, you can see there at the bottom, and some health information or health education that can be brought to bear in different settings.